pillars. Hi guys, welcome to this video of this video course about vertical preparation. In this video I'm going to talk about what are the pillars of long-term dentistry, because when we go to courses and congresses, okay, we see stunning, amazing cases, but in the real world, what are we interested at? What is our main interest? I just want you to think about what are your main concerns in your daily work. What is your goal in your daily work? Because this is, it may seem an easy question, but you will realize that this is not an easy question at all. Because, for example, I will do the example of the endodontic world because this is one of the easiest in order to do this kind of example. When this is a slide from a very famous, endodontist, an American one. Of course, the endodontic world is amazing, of course, but when we see this sort of slide with this sort of cut of the apex without considering the coronal anatomy of this teeth, what is the message of this slide? The message is that the goal of the endodontic treatment is the apex. The goal of endodontic treatment is the look of the X-ray. The goal of the endodontic treatment is to reach the apex to fill as much lateral canals as possible. But the reality is that still nowadays, we know that this is not something that may be related to the success in the same measure as we believe. Because, for example, the role of the lateral canals on the percentage of success of endodontic treatment is still something that we can debate on. And even on the length, we know, for example, that endodontic treatment 1 millimeter short from the data that we have has the same percentage of success. And we know also that there is a difference between the anatomical apex, the radiological apex. So the question is not so easy, but when we look at this kind of slide, the message is that the goal is, from a radiographic point of view, to reach the apex and to fill lateral canals. So, if you think that that way of doing endodontic is correct, the first time, like it happened to myself, that you will be able to hear John Kademi. He is a very famous American endodontist. He did the review of the cases successful after 20 years. And the stunning result is that after 20 years, most of the successful cases are cases without a golden standard endodontic treatment. John saw that most of the teeth that after 20 years, not 5 years, are still in the mouth of the people are teeth treated without a good standard, but with crappy endodontics. Of course, I'm not saying that doing crappy endodontics from an endodontic point of view is better, but I just want you to start to understand that probably if you are starting to think about the real goal of our procedure, that it is the preservation of the whole tooth, probably the endodontic treatment is not in the top list of the priority, because this slide is saying this. If we think that our goal is the preservation of the tooth, and after 20 years, most of the teeth that are still in the mouth of the people are without a good endodontic treatment, probably the endodontic treatment is not in the top part of the priority for a successful outcome. And this is something that is counterintuitive. And this is something that we have to match in our mind. Because how can we match the knowledge of a good endodontic treatment, a successful one, with the data that after 20 years instead, teeth with bad endodontic treatment are still there? This is the reason because we put a lot of effort in order to define the pillar of successful, the pillar of long-term dentistry between different times, we have to understand that there are different kinds of outcomes. There are process-centered outcomes, result of procedures technician performs, like endodontics. When we do endodontic procedure on the apex, this is a goal but related to a procedure, and the procedure is something decided by another person, by a man, by an organization, not by nature. This is the point. Process-centered outcomes are goal related to a goal decided by a human mind. Another form of outcome is the clinician disease-centered outcomes. It is about signs and findings that the clinician observes as evidence of treatment efficacy or lack thereof, like for example, radiotransparency. The clinician sees a lesion, do the endodontic treatment, is in the apex, successful. He does the X-ray after 6 months, the lesion is still there. Okay, so the case is successful or not? This is the question. But if the patient is perfectly fine, the tooth was hurting and now the tooth is hurting no more, we have accomplished a big thing, that it is the preservation of the tooth, maybe, despite the bad radiological findings. So we have to divide the outcomes in these three big families. Process-centered outcomes, goal towards something decided by the human mind. Even clinician disease-centered outcomes are something that we have decided. Because, for example, for endodontic, we can decide that the radiography is just a normal X-ray, or an orthophantomography that we know that is much more sensitive, or a CBCT that it is much more sensitive. So even here, the threshold can change. Instead, patient-centered outcomes is bread and butter dentistry. Is the outcomes that patient notice and care about: loss, survival of a tooth, pain, no pain, and the normal function. The problem is that if we have the right goals in the mind, we strive in a direction. If we have instead the other goal in our mind, we strive in another direction. And we go in a direction losing the real issues. Because this case, for example, of course, from an endodontic point of view, is a good one. But if we take in consideration other factors that are much more important for the long-term prognosis, this case is not more a good one. And you will understand why. The same happens in prosthetic, for example. This is a great case. I have a huge esteem of this colleague, for example. But the problem is that in prosthetic, we do the same mistake. I mean, we put a lot of effort about the final aesthetic of the restoration, about how much space do we want for our restoration, and we lose who is paying the price of our ideas. That is the tooth structure. This is a great crown, sure, but what I want to analyze here is the reasoning behind that. We have to start to think about the price we are going to pay biologically and biomechanically for the goal that we are giving. Because we will realize that many things that we do and that we think that will lead ourselves to success are not helping us. So you will realize that doing it, the shoulder, the perfect shoulder, the perfect seal of the shoulder of the crown, these are just process. And that the process outcome is related to the patient outcome. We think that they are the same, but they are not. So again, before starting this video, I just want you to understand exactly the difference again between process-centered outcomes, RIP, clinician disease-centered outcomes, and patient-centered outcomes, because this, in the ideal world, should be the same. But in the real, actual world, they aren't. So we have to keep in mind that we have to strive for the right one, because striving for the right outcome will bring us to the right goal, that it is a successful office with happy patients. So, because I want to do bread and butter dentistry, if we ask to the patients and we just translate in dental words his desires about a prosthetic treatment, what the patient can ask from his dentist? I don't want my tooth to break after you drill my tooth. Low risk of abutment fracture. I don't want my tooth hurts after drilling, so low risk of pulp complications. I don't want that my gum move far from the crown, because aesthetically is not nice, low risk of soft tissue recession. Doctor, what happened if I have a decay under my crown? Because we know and he knows that this is a problem, so low risk of decay. And also, doctor, how much time are you going to spend with my mouth wide open in order to do this work? And so it is the request of a fast protocol and the reduced chair time. And instead, if these are, try to think about in this way, if there is something more that the patient can ask to ourselves in order to, that we can translate in dental words. And in the same way, if these are the patient desires, try to think to what are your desires, the dentist-centered outcomes. But think in an easy way, bread and butter dentistry. Because if you are a dentist, we can do a lot of reasoning about what we want. We can do a lot because we tend to complicate things. This is the reality. We tend to complicate things thinking to protocols, to biology, to what other colleagues can think. But at the end, we as dentists want few things. We want a procedure with the low stress, because we have to work many hours. I work many hours every day. I want something that is forgiving, because you know, our patients sometimes are not easy. I cannot be in the right mood that day. So if I have a technique that gives a little bit of tolerance to small mistakes, it's something that I like. Instead of a very rigid, strict protocol in which every small mistake brings me to the starting of the procedure. And the profitable technique. Because if I spend 1 hour for doing a crown, instead of spending 2 hours for doing the same work, my profitability is much more. And I found all the solution in the vertical world. Vertical has been the solution, the answer to all these questions. To the questions of the patient, of reducing pulp complications, reducing soft tissue complication, reducing abutment complication like fracture, reducing decay. Because you will see that vertical preparation from a geometric point of view show a much better seal and a much better marginal accuracy than the horizontal one. And they are easier to perform, so we are also faster. So with the vertical world, we are coping with the patient desires, with the patient request, and with the dentist also. Because the technique is easier than doing a shoulder preparation. Small problems can be rescued with some small tips and tricks. And because this is easier and is faster, the procedure itself is also more profitable. So now I want to do a step back, because the problem nowadays is that we dentists, when we go to courses and congresses, we think in a mechanic way. We are too focused on techniques and protocols. So now I want to speak about the pillars, back to the basics, the pillars of long-term dentistry. We did this sort of word, primum non nocere, first do not harm. Most of us when we took our degree in medicine. And it's quite interesting that other companies in the world not working in the medical field understood something better than us. I want to speak about the Hiro brand because I was in love with this sentence. Behind design and aesthetic, there is a world of technological innovations whose main purpose is your safety. This is a sentence from the Hiro helmet brand. They have perfectly clear in their mind that if we have a ladder of priority, safety is at the first place, design and aesthetic is at the second place, and duration over time is at the last place. So, honestly, you as a dentist have this priority? If you look at courses, congresses, book dentistry, do you see that we respect this priority? Or we put design aesthetic maybe at the first place, duration over time of the work of the restoration at the other time, and we don't focus enough on safety. Safety, the biological safety, is the first point, is the top priority. And if we joke many times that we as dentists are a mix between a doctor, an engineer, and the artist, the dentist, I think that we have to spend a little bit of time today with this video talking about biomechanics. It has the analysis of biological structures under static or dynamic loads. Because the question is, we drill in order to obtain something, but what happens when we drill? This is the main question. We have to focus much more on what happened to the tooth, to the biological structure when we are drilling something. Because on this topic there is a sort of wrong concepts and the hypersimplification. This is an article speaking about biomechanics, and you see that in this slide it's quite clear for these authors what is the risk of fracture for this teeth. On the left you see that there is a tooth without any kind of problem. In the second place we have a tooth with the occlusal space. In the third with the endodontic access. In the fourth with the loss of the marginal ridge. In the fifth with the loss of both marginal ridges. So this is the hypersimplification of the biomechanic concept. Now, we have to understand a little bit about how load and materials behave, what they mean. According to Newton, you know, something like him, if we add, I take this pen, if I add a strength, a force to this pen, like this, okay, you don't see this, but there is a tension to this pen. I mean, if I add the force to a body, you will have a deformation of this body. You can see or you can see the deformation according to the material. Like for example, if I try to do this on this, that it is quite stiff, you are not able to see the deformation, while I'm perfectly able to bend this with a little bit more strength, but I'm able without any effort to bend this, for example, okay? But there is always a force and a deformation at some level. So, according to the direction of the load, we have different kind of situation. When we have a body and we try to compress, we have a compressive force. When we try to stretch a body, there is a tension forces. And we have a physical deformation. Just to give you some example, this is an example of compression. You see, compression, and this is that tension. Elongation. This is another example. On skyscraper, people doing this kind of buildings have to work with the problem of the wind. When we have wind on a skyscraper, there is a tendency to the skyscraper to do this kind of movement, this kind of flexion. So people working in this field have to know exactly which kind of force they are dealing with in order to avoid catastrophic consequences. And this is interesting to see, for example, that in order to avoid this kind of problem with wind, architects and engineers put something like a big, super big ball of iron. This is the Taipei 101. They put big ball of iron, of steel, 6 meters, 10 meters, very, very big one. Because this works against the force, the oscillation made by the wind. These are called the tuned mass damper, and they're placed in the top of the skyscraper. Another interesting concept is that we tend to simplify, thinking that when we bend, when we push this skyscraper, the vector is just this, but this is not the reality. Like in the same way, when we take a vaulted arch, you know that there is a pressure from the stone in the middle to both sides, but we have only these vectors, or are there any other forces that we have to involve? Galileo Galilei, Italian one, already in the 1600 was able to understand that when we apply force may be divided in two vectors, not just one. We have always two vectors. So if we take the example of the vaulted arch, we have one vector that it is the vertical one, and another vector that it is the horizontal one. You see? You have two horizontal vectors. So when you have a vaulted arch and you apply a pressure on the top, there is not just the force, the vertical one, but you have also a pressure in this direction. And this is very interesting because we can do a lot of analogies between the vaulted arch and the tooth. So we have to understand at this point the relation between the material and the load. The relation between the material and the load is described, firstly, understanding the inner feature of the material. We can divide, simplifying the concept, the material in two big families, brittle materials and ductile materials. What is the difference? Ductile materials is like steel. What is? A material that under load starts a deformation before cracking and fracturing. Okay? So what happens? That we have a body that starts to deform, and just after a certain amount of deformation, we have deformation of a crack, and after deformation of a fracture, the catastrophic failure. Instead, brittle materials are like glass. You see zero deformation, and the first sign is the crack and after the fracture. So these two big families are very different about how they behave. So you have to understand, like, for example, steel and glass. When you apply a force to brittle material in general, we will see this in detail, are quite strong in compression, but they are quite weak in tension. So when you do a bend, you apply a compression on this part of the material, but you apply a tension in the central part of the outer surface. And being weak in tension, what happens in many cases is the fracture or the cracking of the material. These are some dental materials, and you see that most of our materials share a difference between how much they are able to withstand compressive force and how much they are able to withstand tensile forces. So for example, enamel is 384 MPa in compressive toughness, while tensile toughness is just 42, something like 90% less. Dentin, slightly better, but 297 MPa compressive toughness, just 61 MPa tensile toughness. Porcelain is quite similar. Porcelain is 340 MPa, but just 70% less, 108 tensile toughness. So when we deal with our teeth and with ceramic, we know that bending is the most dangerous load in our field, because most of our dental materials are weaker when under tension forces, and the failure is quite catastrophic. Of course, this is about the inner feature of the material. Deformation is related to the inner feature of the material, but also the section of the latter, because if I'm able, for example, to bend this thin pen, I won't be able to bend a thicker one. So, when we think about a material and the deformation, we have to always to take in consideration 4 parameters: load, type of load, material, and the section of the material. I'm going to assess all this. So when we see a crack, what is a crack? On a tooth, like on a glass. Crack is the only way that the brittle material under load are able to release the stored strained energy. Crack allows the relaxation of the material in that area. It's a way that brittle materials has to avoid or participate the brutal fracture. So, when we see a crack in the mouth of a patient on a tooth, we have always to ask ourselves, is the load the reason of the crack? Is the type of load the reason of the crack? Is the material the reason of the crack? Or is the section of the material the reason of the crack? Because according to the answer that you are going to give to each one of these questions, this will lead to a different treatment. Just a case. Lower first molar, painful. High sensitivity to cold, impossible to bite. I did the diagnosis of cracked tooth. I did the anesthesia. I did the flattening of the occlusal surface. This is always a first step that I do when I do this kind of teeth. You see here the crack from the distal marginal ridge. On teeth without restoration, on molar teeth, the crack is always, in my experience, from distal to mesial, never the opposite, unless you have a restoration that gives a weak point, a starting point. Endodontic treatment, you can see here again the crack going exactly in the pulp chamber. Again, another vision of the crack, you see, going straight to the pulp chamber, and the zirconia crown. In this case, what is? It's enough to see the initial photo of this patient that I did during the first consultation to understand that this patient has parafunctions. Look the wear that he has on his anterior teeth. Look the wear that we have also on canine. And because canine was worn there was a sort of function group, and probably in some movement there was much more involvement of this sort of guidance between the upper and first and lower first molar that the other did. So here was load, because of course the patient has some parafunctions. We see that we have a worn dentition, but type of load, because we have also this kind of movement doing lateral movements. So this is what happened. We have a force, a tensile 1, the vectors divided in the vertical 1, okay, but also an horizontal 1 that then to split the cusp. And after a while we have the crack, that it is, I want to remember, the only way a material can release the energy in order to avoid the catastrophic failure, the fracture. Another similar case, you see, patient complain on biting on this lower right molar. A crack is present from distal to lingual. You see that there are also some erosion spots on this tooth. I did the lowering. Here is the erosion spot. Here is the crack of this tooth. I remove the amalgam, and you see exactly the design of the crack. So, what I do? I try to change how load is applied to this material, changing the conformation. I did a flattening of 2 millimeters. I did, if you see, a small bevel, in order to give a different kind of force, more compressive, to this tooth. And I did a direct overlay in a case like this. You see that there is a crack also here going to the mesial, and this is what happened. Material. So once we have understood that load and the type of load are what are, we have to understand the material, because when we deal with natural tooth, of course, we have not many materials. Simplifying, we can say that we have enamel and dentin. Enamel. From an anatomic point of view, I just want to make clear the inner anatomy of a tooth, because it's quite interesting also for other considerations. The dentin is something like concave, while the enamel is convex. So, enamel is not a structural material, has no support function. It has a role in relation to increase the stiffness of the whole tooth, but it may be replaced in a prosthetic way. For example, it's easy to replace enamel because the ceramic is quite similar, but we can work with increased thickness of ceramic. This is an image from the Pascal Magne book, and we see that if the natural tooth on the top of the image is that strength, we see that in the second row, we see that adding a veneer to a natural tooth, the final stiffness is even more. And the same happens, for example, when we add the veneer to a tooth with a broken part, or with a composite restoration plus a veneer. We see that adding an increased thickness of ceramic can replace enamel quite in a good way. Of course, this is a simplification because enamel has a quite tricky network of interlocking with dentin, but if we want to simplify things, we can say that we can replace in a quite predictable way, you can replace enamel. On the second point instead, we have the dentin. The dentin is the real bank of the strength of the tooth. Because when we lose dentin, all these biomechanic problems start to arise. We have the loss of dental structure above dentin that leads to loss of stiffness with bending. Bending starts to put tension forces on the elements, and we have, with the time, also the accumulation of fatigue. It's the same thing of, a tree with a branch. Okay, I have not so much strength, we can say, but if I bend that branch of the tree 1,000 times, 2,000 times, 3,000 times, sooner or later, that branch will break. And so, if we have an endodontic treatment and we have the luck of the sealing of the pulp chamber, the lever arm is increased. In the same way of the branch, if instead of moving this branch and having this possibility, the branch is much longer, so I am able to flex much more. Doing this, the accumulation of fatigue will be quicker and the fracture will arrive before. A lot of emphasis in the last years has been given instead to the importance of marginal ridge. And this is related to an article that, in my opinion, is one of the most controversial, I can say, and misinterpreted study. This is the famous study of Rhee. This is a study made in 1989 by Rhee, Messner and Douglas, and is about the reduction in tooth stiffness as a result of endodontic and restorative procedures. The conclusion of this study, that it is quite misleading, is that results on 42 teeth indicate that endodontic procedures have only a small effect on the tooth, reducing the relative stiffness by 5%. This was less than that of an occlusal cavity preparation, 20%, I will speak more about this. The largest losses in stiffness were related to the loss of marginal ridge integrity. MOD cavity preparation resulted in an average of a 63% loss in a relative cuspal stiffness. The results indicate that endodontic procedures do not weaken teeth with intact marginal ridges. So this is the result of the study of Rhee, that all endodontic success just steal 5% from the cuspal stiffness reduction, and occlusion mesial cavity without endodontic treatment 35%, while an MOD from 55 to 63%. So what we understand from a study like this is that as long as we can do endodontic access just with the occlusal access without touching the marginal ridges, there is not so much harm to the tooth, but that instead touching the marginal ridges leads to a fragile and weak tooth. This study is quite biased because on this study you will read in the article that an occlusal cavity of 1/3 of the intercuspal distance lead to a loss of 20%. 0. I will show you a slide immediately after. Because the real problem is that on this study many things were not analyzed in the proper way, like loss of the marginal ridges is always linked with occlusal cavity. We have no slot cavities. Slot preparation, where you can assess really what is the influence of the marginal ridge, are not considered. The endodontic success done in this study are done only on second premolar with very small straight access. And also no cyclic fatigue was analyzed, but there are many flaws in this study. But just to understand, you have to understand me, this data of this 5% also comes up always in courses and congresses. This is, for example, an article about the conservative restoration of single posterior endodontically treated teeth. And you see that when we speak about biomechanics, again here, highlighted in yellow, This concept comes over and over again. Endodontic treatment itself has a relative influence on tooth resistance. Rie and al. Have showed that the endodontic success creates a decrease of 5%. Much more influence is linked to the loss of one or both marginal ridges, with a loss of 46 and 63%. And this brings to the old concept that this is the risk of fracture, and this is the hypersimplification of the biomechanics of teeth. So, going away from the study of Rie, I just want to spend a little bit of time on other articles, because the literature is full of other articles with much more interesting informations. This is a study about to study the force required to fracture teeth with occlusal or MOD cavities. And they did a standardized approach about the width of the occlusal cavity, doing this of 1/3 and 1/4, and adding 2 slots on the marginal ridges. So, in this study, they analyzed the fracture resistance of a natural tooth, an MOD wide occlusion, MOD narrow. The difference between the wide and narrow is between 1/3 and 1/4 on the intercuspal distance. Occlusion wide, again 1/3, and occlusion narrow, again 1/4. The article is Effect of Prepared Cavities on the Strength of Teeth, Journal of Operative Dentistry. And when we see the result of this study, we see quite strange results, because we see that occlusal narrow, you see here, occlusal narrow is load is 333, while adding the slots 334. And again, also in the other case, we have 216 versus 213, so there is not so much difference between adding or not the marginal ridges, the slots cavities. Instead, the real factor that makes the difference is the width of the occlusion part. Even the authors of this study were amazed with the result. In fact, they wrote that the surprising finding is the lack of significant strength difference between the occlusal and MOD preparations. A commonly believed concept is that mesial and distal marginal ridges form a circle of enamel that is important to the strength of the crown. Breaching the circle with mesial and or distal boxes should weaken the crown seriously, but this did not prove to be true. So we see from this study that the most important factor is the width of the occlusal cavity. This is another interesting article, Fracture Strength and Fracture Patterns of Maxillary Premolars with Approximal Slot Cavities. Premolars with MO/DO slot cavities or slot amalgam restoration exhibited minimal fractures that involved enamel only in the majority of the cases. This behavior was similar to what was observed with intact premolars. In contrast, premolars with conventional MOD cavities or MOD amalgam restorations exhibited severe fractures that involved enamel, dentin, and the root in the majority of the cases. So, remember the vaulted arch and this concept. We have to understand that the critical areas of a tooth are these: the occlusal part, how width is the excess, and the pericervical dentin that it is on both sides of the tooth. At this point, we can analyze the section of the material. When we analyze the section, we understand that if the material is the same, like always denting, and the load is the same, then two factors that can change are the type of load, compressive versus lateral movements with tensional forces, and the amount, the section of the material. So this is the reason because I love in endodontics doing minimal approach, preserving as much as possible, of course considering the access to the mouth of the patient. So this is the reason because we do the so-called truss access, leaving that bridge of dentin connecting the buccal and the lingual wall. This is why when I did this premolar with this mesial decay, if I can, I don't remove this bridge connecting the palatal and the buccal wall, because this gives a lot of added strength to this tooth over time. And you see, again, truss access, same concept. Opportunistic access, accessing the tooth through the decay. Minimal access. The concept is that we have to say dentin, because more dentin we have, less deformation we have. And this is a working philosophy, preserving the internal structure, doing the endodontic treatment, and finalizing, preserving the external structure, because more structure, it has less bending, less fracture, more success. Again, I want to say again the concept. Loss of dental structure, loss of stiffness, bending of the cusp, fatigue, crack, fracture. Again, our tooth is the same of a vaulted arch. And we have in the top, in the middle, the interaxial dentin, and on the sides we have the pericervical dentin. The dentin that it is between the bone and the 4 millimeters over the bone. This is the area where most of the load are charged. So when we apply a force in this area, for the principle of Galileo of two vectors and the example of the vaulted arch, we have a force like this and a force like this, two horizontal vectors. Of course, I just want to remember that the load is chief, because if we have just a light load, we have zero deformation and zero problems. But if we have, like in this example, we have a huge load, we will have the collapse of the structure. And this is what happened in dentistry. The fracture, the collapse of the structure. If there is no load, even an impossible situation will never break. When bending is risky, the problem is the bending. The bending is caused by loss of stiffness. So what do we want? We want to go back to the root of the problem, and we have to stiffen the restorative complex. So we need to develop over time, with a bit of clinical experience, to match how stiff a tooth is, how good or bad an occlusion is, and which kind of prognosis in the time, in order to understand and decide a treatment plan. Because this is what happened. We have a healthy tooth, and we have this sort, the blue line of horizontal forces on the pericervical dentin. We do a hole, and we start to have more accumulation of forces on the pericervical dentin. This is something that it is true also for vaulted arch, like in this case. This is the famous Constantine arch in Rome. You see the Colosseum behind. If you see, when you see this kind of buildings, the main arch is the bigger, and the small on the sides are smaller. Why? Because this is what happened. The bigger arch put a lot of force on the side. So, what is the solution for the architect building this kind of building of arches? Or you have to do a thick column on the side, or if you want to do something that it is more elegant, you have to add two small arches counterbalancing the force. And this is what here we are doing. This is Milan. You know, we are Italians, so Milano is the capital of fashion, capital of many things in Italy. Milano, this church was built 500 years ago. 500. But it's nice to see the first drawings from Lucio Vitruvio Poglione of 1521. At that time, without computers, with their primitive instruments, they already were able to grasp these concepts. Look on this map. Look the main arch, how they were studying, how they were designing the shape and the measure of the other arches. And this is how everything is working in a perfect way since 500 years. Lucio Vitruvio Poglione, 1521. 500 years, and this church is always in the same position. Because at that time they were perfectly clear with their experience to understand this mechanical concept. And our tooth, again, we put our hole, we do the force, and we have much more force with horizontal vector. Of course, we cannot put another arch like they were doing with the church. So what can we do? In order to reduce this movement, we can put a collar. A collar that it is named a ferrule. Ferrule comes from Latin viriola bracelet più ferrum, iron. And it is, in physics, an object used for fastening, joining or reinforcement. They are often narrow circular metallic rings like bracelets. In our field, these are crowns. Of course, if I have an object that it is moving and I want to stiffen the complex, I have to use something that it is stiffer than the material itself. So it's quite useless if I want to reduce bending on a compromised tooth to use composite, because composite is not stiffer. If I have to stiffen the complex, I have to do something stiff, like metals, zirconia or ceramic. But we have to understand that in order to do a crown, we have to drill some material. And drilling some material will reduce the section of the most important material, that it is the dentin itself. So we have to be careful about doing a very limited amount of reduction. Ideally, we would like to remove zero dentin, because removing zero dentin and just the enamel is the best way to improve the behavior under load of our teeth. Because if you are able to preserve the whole dentinal core and put a crown, the final result is a never-breaking restoration. So again, these are the critical areas, the interaxial dentin and the pericervical dentin. When we do a shoulder, what happens? That we remove dentin, so we reduce the section of the most important material, the dentin. And if we do this too much, and if we put also a big endodontic access, like people was doing in the last years, because they were looking for the apex, so for the straight access canals, for looking at for having the complete vision of the pulp chamber, what will happen is that the crown, the tooth, despite the crown that it is stiffening everything, will develop cracks and will fracture. So what we want is moving from a fragile situation where under load our teeth will break to an anti-fragile, to a robust situation, where the final result of a tooth with a crown is a robust one, able to withstand the occlusal forces without any problem. So, horizontal prep have another problem. They not only reduce the thickness of the dentin, that biomechanically speaking is the most important material, but they create also a snap point prone to crack initiation. So always keep in mind that more structure, we have less bending, less fracture, and minimal endodontic plus vertical technique is the best way. But not all the vertical techniques are the same. I want to like this, because the leading vertical technique do a huge removal of dentin. So we do a vertical technique, but biomechanically speaking, we have a weakening, a strong weakening of the tooth. This is the reason because in our Tomorrow Tooth protocol is different from the other vertical protocols for three things. The bar protocol, we will see this in detail, that it is different from the conventional one, and the minimal prep protocol, because like this, these are teeth prepared for crowns. If you are able to prepare teeth like this, removing just enamel without touching the dentin, we will be able really to increase the stiffness and the chances of long-term outcome of success on these teeth. The higher concept, first point priority is safety. And this is the evolution of the bar. We will see this in details in other videos. This is what we do, because the first priority is safety. We prefer to move the risk to the crown. We have found solutions in order to make also the crown longevous. But if I have to choose between the fracture of the crown and the fracture of the tooth, I already did my choice. And because working with this reduced thickness of the crown is quite challenging, we have developed a special protocol for the lab in order to manage vertical crowns. And we decided everything. We decided which kind of model, which kind of material. In this case, for example, this is a polyurethanic material. We changed the spacing strategies in the CAD/CAM procedure in order to avoid chipping and improve seating. This is what we do. So the take-home message is that biomechanics is the most important part. We have to remember that we dentists are overconfident when we take the bar in our hands. We drill we have a lot of space, a lot of material. We drill a big hole in the endodontic access. We drill a lot doing a crown. We do a lot of instrumentation also on the root canals. But the reality is that the tooth is quite small. So remember, more material we leave, better will be the outcome. See you in the next part of this video, and we will also speak about post and how biomechanics is applied to the post science. Thank you for looking at this video. See you guys. See you on the next video.